firstly, I'll start with this particular question, that is the declaration of brain death. And the part B of the question is the ethical principles of end of life care with example. So, by and large, this is what you should write. Okay, just make sure that you have this particular flow chart in mind. Okay, because it's given for a 6 marker question. To explain each detail would be difficult, but if you have written it in a particular order, like say, suppose you started like writing the etiology establishment, then you do the neuro assessment, apnea testing, and declaration of brain death. If you have gone in these particular headings, probably you will get full marks. That is your 6 marks. So, what I individually mean by each thing, I'll be talking to you in the next couple of pages. Okay. So, when we talk about establishment of etiology, definitely we have to rule out the irreversibility of coma. You have to rule out the confounder, presence of drugs or toxins, and along with that, you should have prerequisites that have to be met. That is, your systolic blood pressure should be more than 100 millimeters of mercury, a MAP more than 60 millimeters of mercury, your PaO2 being more than 100, and PCO2 as much as possible. Try and keep it in the normal range, that is between 35 and 45. If you have your reversible etiology established, if you have your prerequisite met, then you can go for neuro assessment. In neuro assessment, you have the irreversible coma, then you go ahead with doing the brainstem reflexes, wherein you just try and evaluate the cranial nerves. So you will be starting off with pupillary reflexes, then you will go and do the oculocephalic, that is your doll's eye, as well as your oculovestibular reflex, your gags reflex, cough reflex, and you have to also look at the motor function by and large. Once these are established and there is no brainstem activity, okay, then you have to go ahead with the apnea testing. In India, it is THOTA, that is the Transplantation of the Human Organs and Tissue Act. That is what we do. So, brain death is usually defined after the second apnea test, which is done at a span of 6 hours after the first. So, you have to talk about that. Is something that you have to give in a brief. And then, if it is inadequate, either of them, probably you have to use the ancillary tests. Okay. Then, after doing all of this, you can go for declaration of brain death, in which you might have to tell who is supposed to do it. If you have this outline for the answer on declaration of brain death, you will be able to get marks. You can start by writing this flow chart, and then you time your answer. You have roughly around 10 to 15 minutes per answer in your 10 marker, right? So based on that, if you write this, you'll be able to answer it accordingly. So if you feel that the time is short, you can write how much ever is possible and come back to this in your revision time. Okay, then you write the remaining half. Okay. So whenever we talk about declaration of brain death, then you have to start by definition, that is irreversible cessation of all functions of the brainstem, include brain and the brainstem. The most important thing is it is characterized by an unresponsive state with absent reflexes and spontaneous breathing efforts. Usually you have to know the etiology. If you have mentioned the etiology, well and good. If not, you can just avoid it. If it's a 10 marker per se, like how we thought about acute ischemic stroke, you can go under the following headings. Okay. So how will you have uh, the etiology? You can either classify based on traumatic or non-traumatic, and based on that you can establishment of cause, baseline conditions, and clinical texting and documentation. And you also, it's better if you have time to write about brain death mimics, because this is what you are thinking about, ruling out the reversible causes, right? So in that cases, what are the reversible causes? Probably it might be hypothermia, Lockton syndrome, high cervical cord injury, botulism, or the presence of drugs and toxins. So this is something that you need to mention. Along with this, right, that confounders, whenever they're present, especially if they are drugs, usually a 5t half time should have elapsed before even you can go into the assessment of brain death declaration. Hypothermia should not be there, excessive hypotension should not be there. Usually this hemodynamic instability, if there's inotropes which are present, they have to be optimized. Remember the rule of 100 that we have mentioned earlier in the classes. Also rule out the presence of any metabolic causes like hypoglycemia. Okay. So if these are there, and these things are ruled out, so you can be sure that the confounders for brain death is ruled out. Okay. So after that, the next thing is clinical testing and documentation. Usually, whenever there is an anoxic brain injury, the period of time which is supposed to be there is roughly around 24 hours. For spontaneous intracranial bleed, it is roughly 6 hours. Head injury after a traumatic brain injury is 6 hours, and major trauma, neurosurgery, aneurysm, roughly around 4 hours. Okay, so this is something that you can write if you have time. Otherwise, you can omit it. Testing very much important. Whatever tests you do, especially your brainstem reflexes, your cranial nerve examination, mention the afferent and efferent. Okay, so all of this you have to look into it, read again and write it. And very importantly, prerequisites for testing it, that should be present. Whenever you're thinking of all of this, make sure that there is no c-spine injury, make sure there is no CSF autoria. Okay, because if at all any of this is present, that can be detrimental, and it is not right to do it. Okay, you might cause more harm for such patients. Okay, so whenever you're writing, please make sure that you write the afferent and the efferent. So pupillary, afferent is 2 and efferent is 3. Oculocephalic, your Doyle's eye should be negative. Okay, your afferent is the 8th cranial nerve, and the efferent is 3, 4, and 6 cranial nerve. Oculovestibular, as the name goes, it's cranial nerve 8 is the afferent is cranial nerve 3 and 6. Okay. Cough reflex, gag reflex, you know very well. Okay, that is the 9th and the 10th cranial nerve being afferent and efferent respectively. Apnea testing, it is the most essential part of declaration of brain death. Okay, so make sure that you do apnea testing after you have removed all the confounders and you have optimized the patient. Okay, be it with respect to carbon dioxide retention, or hemodynamic instability requiring inotropic supports, etc. Okay, so usually you can write it in a stepwise fashion. Pre-oxygenation, then draw in an ABG, uh, continue insufflation method or a CPAP method for the apnea testing for a period of 10 minutes. Withdraw apnea testing if there is worsening of hemodynamics, and then do an ABG after a span of 10 minutes. Okay, if you have done this, this usually should involve your clinical testing and documentation. Then it will come to interpretation of apnea testing. You know very well, if there is a 20 millimeter rise after 10 minutes from the baseline, that is indicative of brain death. Or else, roughly they say anything more than 3 mm of Hg per minute increase in PeCO2 level is an indicator of worsening brain activity, that is your brainstem death. Okay, this after doing the first apnea test, you have to do a second apnea test after 6 hours, and then at that particular time you can declare the patient as brain dead. Okay, usually if one of these tests are not okay, the law in India is still not clear, we are still dependent on apnea test, but elsewhere the use of ancillary tests for the declaration of brain death is acceptable. What do you usually do? You do a DSA to see the reversal of flow. You can do cerebral angiography, EEG, SEP, okay, one or SSEP, etc. Okay, so you can just name the test. That's more than enough. Okay, if you have given what are the testing, but if they specifically ask what is this particular test, then you might have to elaborate on that. Okay, so you please read up about all these things as well. Okay, then comes to the certification, because your question was declaration of brain death, so you should also involve this, who is the person who is involved in declaration. So usually it should involve the treating doctor. Along with that, usually there will be a nominated doctor as per the act. So it can either be a physician, intensivist, anesthetist, but definitely it must consist of a person with neurology background, either a neurologist or a neurosurgeon. Okay, along with this, you should be remembering that this patient should not, I mean, this doctor should not be directly involved with the transplant team. Okay, so two doctors must be present at the time of assessment. They both have to agree to each person's assessment, and only then they can declare brain death. So remember, start with ruling out confounders, prerequisites, neuro assessment, that is irreversibility of coma, followed by brainstem reflexes and cranial nerve examination, apnea testing, test 1, ABG, before discontinuation from the ventilator, document the PaCO2 level. 10 minutes later, again look at the CO2 level more than 20, then probably brain death. Repeat the same test after 6 hours. Test 2 is also similar to test 1, then you can declare brain death. If anything is inadequate, use ancillary tests. And after that, two doctors who have been certified. One is a treating doctor, other one needs to be a neurologist or a neurosurgeon. Okay, so based on these two people, you can go ahead and declare the brain death. Okay, so this is by and large about the declaration of brain death. So part B of the question was, what are the ethical principles of end of life care? This is a very easy question. Okay, usually they will club like this. Okay, if the part A is very lengthy, the part B will be very small. Okay, so all of you know, they are usually called the four pillars, but right now, if you see the palliative care, principles, they have added two or one more extra, that is dignity, autonomy, beneficence, non-maleficence, social justice, and dignity. So you can write whatever example seems fit to you. Just remember that, okay, whenever you're reading that particular thing, remember your example. That's more than enough. It need not be the same thing that I'm mentioning here. Autonomy, you know very well, it's the patient's right to make decisions regarding his or her life. It is still legal in India as well, regarding refusal of treatment. Say suppose a patient has carcinoma, CKD, they are having the autonomy to say that I do not want dialysis, I do not want to take chemotherapy. Okay, that is the part of ethical principles, owing to autonomy. Beneficence, you should remember this is something which actually deals with the doctor who's treating. Okay, so this is something that the patient, it is the act doing in the best interest of the patient. Okay, especially it is aimed at enhancing the recovery or improving the recovery at that particular time, or very minimal, like to improve the quality of life. Okay, so for example, sometimes for beneficence, what you need to understand is the doctrine of double effect. So, you give pain management for a certain group of patients with cancer. At that particular time, questions like the family might ask, yeah, this put the patient to sleep? Can the patient become unconscious? Yes, it's not an intended effect, but yes, it is something that we are looking at the broader picture. So the main aim or the thought of the doctor was the benefit, that is, patient is in intractable pain and you are starting a painkiller. So that is about beneficence. Non-maleficence, again, it involves the doctor. It is to avoid, as and when possible, any treatment or procedure which can actually prolong a suffering. Okay, rather than helping the patient. At times it can even worsen or harm the patient. Example, if the patient is in terminal illness, has come to the ICU with metastatic cancer in a very poor state, and he's dropped his GCS probably because of CO2 retention, CA lung is the thing. At that particular time, intubating this patient would be futile because you're prolonging life unnecessarily. So, such things like withholding is something which is acceptable. It is not maleficence. That is, you're doing it with the benefit of the patient at mind. That is why it is coming under the principle of non maleficence. Okay. That's just social justice, which we all knew. Take an example of COVID itself. Okay, you know that any patient who was young, without any comorbidities, at time when beds were really very scarce to get, especially ventilator beds, we usually took patients of younger age group. Wherein possible, if their patients are elderly with multiple comorbidities, especially with CA and all, if at all there was a crunch, we would choose the younger population. Similarly, whenever we are providing care, we usually not don't see anything about the economic or a financial background. We just do the best possible for all patients. So you can give examples like that. Okay, so dignity is one thing which they have added quite recently. Okay, so in that patient, you have to remember, whenever you're treating a patient with terminal illness, or for that matter any patient in the ICU, you should remember that the dignity or the self-respect of that patient is maintained. So like personal hygiene, etc., has to be addressed. Okay, probably the patient is unable to communicate for any reason, but at that particular time his likes and dislikes should not be neglected. Okay, his personal hygiene, his nursing care should be in par, if not less, as compared to any other patient in the ICU. Okay, so by that they should feel that they're not being neglected because of their illness. Okay, these are the things about your ethical principles of end of life care. Okay, so remember, it's a very lengthy question again. If you write it in certain headings, if you fill up your answers based on the headings and come back later on if there is a crunch of time, it is okay. So this is something that I just put in because, please excuse me if my handwriting was not good, but yeah, this is something that you need to do. Okay, stabilization and evaluation of a comatose patient, then probably rule in the reversible causes either by examination or imaging. Then you do the brainstem reflexes, apnea testing. and then probably go ahead and declare brain death. Okay. Sometimes you see motor responses which might not be compatible with the normal brain function, okay, like your Lazarus reflex, etc. Okay, sometimes you can see facial twitches, finger twitches, which the family might say, yeah, the patient is having some action, right? So these are some motor responses which are seen, but it's okay. Okay, you can just look at these things and tell them that this is not incompatible. This is incompatible with normal brain function. Okay, this is something that you can tell the family. Again, remember your root values for your brainstem reflexes. Okay, from starting from the eye, going on to the prerequisite while doing your doll side. Make sure there is no C-spine injury. Okay, and there is no CSF photoria or any damage to the tympanic membrane when you're doing any calorie testing, etc. Okay. So ancillary test, remember your four vessel cerebral angiography, radionuclide scan, and a CT angiography. Okay, so the gold standard is a four vessel cerebral angiography where it shows the reversal of flow. Okay, so just remember that. Next question is quite straightforward, I think. So this is the question that most of you would have answered easily. Expanded dengue, warning signs of dengue, and diagnosis and management of HLH, which might be a probability that it is a worsening case of a severe inflammatory condition. Okay, so most of you might have written the right answer. Okay, so expanded dengue is nothing but it is an atypical or unusual manifestation of dengue fever that extends beyond the classic febrile illness with thrombocytopenia. Okay, so if you have written the words like atypical, unusual manifestation, which is not defined as per the WHO criteria, one of these words if you have written, 1 mark you will get. The second mark you will get when you write what are the components of expanded dengue. That is something like multi-organ dysfunction, which is usually immune-mediated mechanism. That is either acute kidney injury, encephalitis, myocarditis, rhabdomyolysis, or acute liver failure. If you have written these two things, you will get your full marks. Okay. So coming to the second part of the question, that is warning signs of dengue. Usually, this is just telling that basically they look at the phase what it is. If you've written that it usually happens in the second inflammatory phase of dengue, that is good. Okay, it actually follows the febrile phase. After the febrile phase, patient can show signs of warning. Okay, wherein you will see that the hematocrit goes up, there is a sudden drop in platelet count, right? That is the graph that you see. So it is usually the signs which are seen are severe abdominal pain, usually associated with vomiting, dull aching, and a persistent type of pain. Vomiting, usually it will be increase in frequency and associated with dyselectrolytemia and acidosis. You can write about mucosal bleed that usually happens because of coagulopathy and worsening thrombocytopenia. Restlessness and lethargy, that is usually due to a worsening shock state. Okay, it can be either due to pure perfusion or sometimes due to dyselectrolytemia. In worst case scenario, it can also be due to acute kidney injury, and that is secondary to rhabdomyolysis. Hepatomegaly, transaminitis, capillary leak, all of this is also associated with warning signs, which is seen in severe dengue or dengue hemorrhagic fever and dengue shock syndrome. Okay, so these are the things that are warning signs. Okay, when you're mentioning about this, you can either write it in this format wherein each symptom is mentioned and what are the associated things, or you can just write the names and then you can actually mention as the lab parameters and symptoms. Okay, lab parameters like your hematocrit going up suddenly, a platelet count dropping below 20,000. Okay, so those are also showing signs of warning signs of dengue at that particular time. Okay, so you can also mention your liver span. Okay, hepatomegaly, usually if you see a liver span of more than 2 centimeters below coastal margin, that is also considered to be an early warning sign for severe dengue. Okay, so you can either write it this way or anything else that you guys feel like writing, that's also acceptable, but write it under these things. Okay, so if you have by and large written this, you would have definitely got roughly 3.5 out of 5. So if everything is written, definitely you will get full. Okay, but yeah, usually they tend to give a little less. Okay, so they won't give full 5 out of 5, probably 4 if you write everything. Okay, so coming to the part C of the question, that is diagnosis and management of HLH, that is your hemophagocytic lymphohistiocytosis or macrophage activation syndrome. Okay, so you guys should know there is a differentiation. Okay, so usually If the thing was asked as diagnosis and management, you just have to write diagnosis and management. You can omit the first thing, that is your types and causes. I've just written it so that you guys have a look at it when we are discussing. You all know there is a primary, familial, secondary, which is acquired. And secondary, when I'm talking about, it can be associated with rheumatological causes, usually which is defined as macrophage activation syndrome, or it can be associated with malignancy like HLH-M, treatment associated HLH, usually associated with chemotherapy and immunomodulation, sepsis associated HLH, like in cases of dengue that we actually spoke about in the previous two questions. Okay, and sometimes it can also be secondary to immunocompromised state. Okay, if they have not asked types and causes, omit this totally. Okay, no need to write it. Okay, usually if you're writing it, start off by telling that HLH is a rare fatal disorder that can occur due to dysregulated immune response to inflammation. If you write this and underline the thing that it is the dysregulated immune response, that gives a fair idea to the examiner that you know what HLH is. Okay, and then if you write the diagnostic approach like I've mentioned below, that should be enough. Okay, usually it should help. The trigger bell should ring when we have a patient who is febrile. Okay, persistent high grade fever is present. You see that there is a cell lineage drop. Either it is by cytopenia, sometimes all the three cell lineages also can go down, and you also see organ dysfunction. It should ring a bell that this patient might be having an immune dysregulation, probably might be ending up with HLH. So at that time, send in a serum ferritin. Based on the serum ferritin value, you can classify them as HLH unlikely, HLH possible, or HLH probable. Okay. If it's less than 500 micrograms per liter, definitely it's unlikely. You have to repeat all the labs, keep a watch on this patient. Probably some source identification might not be there, and that might be one of the reasons causing bicytopenia and fever and organ dysfunction. But in case you have it between 500 to 10,000, especially if it is more than 4,000, it is possible that this patient is going into HLH. Okay, at that particular time, use your H score. Okay, and if it is more than 169, probably it confirms the diagnosis of HLH. Whenever you see the serum ferritin is more than 10,000, it is probable. Usually can go ahead and start your immunosuppression at that particular time. Okay, so that is what is necessary. Usually, by and large, whatever you do, it has a higher mortality rate. That is the reason it is called a fatal disorder. Okay, so at this particular time, even if you do your when it's more than 10,000, most of the times the H score will be positive. Okay, so there are two criterias in HLH. You all know there is the 2004 criteria which you guys have to remember. Okay, so based on that HLH criteria, you know that it contains these following headings. Try and remember this as much as possible. You can either divide them as clinical or laboratory. Okay, and additional testing, something like that. Okay, you have to remember by and large, if any of the four criteria is present, then it is considered to be HLH likely. Okay, what are they? Fever of more than 38.2, splenomegaly, cytopenias, at least two cell lines. Okay, in that hemoglobin should be less than 9, platelets should be less than 1 lakh, or an absolute neutrophil count less than 1,000. Okay, hypertriglyceridemia that should be present. Usually what sample has to be sent as a fasting sample that has to be usually more than 265 milligrams per deciliter, or else a fibrinogen level less than 150 milligrams per deciliter. Ferritin more than 3,000 is also one of the criteria that you have to take in. The other ones are tissue-based diagnosis, that is your hemophagocytes seen on biopsy, be it from marrow, spleen, lymph node, or even liver. uh, NK cell activity and soluble IL-2 receptor activity is something that is not routinely available. But yeah, you can mention these two as one of the criteria which are involved in the HLH 2004 criteria. The other thing you have to remember is the H score. H score, if you see by and large, it's similar to what is seen in the HLH criteria. It usually consists of 9 parameters. The only problem is it's really difficult to do it from mind. But the weightage for each particular score is more than 169. The likelihood is more than 99%. So what they have done is they have done multiple validatory shown better predictability. Okay, so if someone asks which is a better score, definitely it's the H score. Okay, but by and large, remember HLH 2004 criteria, and remember the name as H score, score more than 169. If you have written this at least if you've written 60%, if you can recall out of this, say they say for more than 4 criteria, if you have written at least 6 out of the 8 criteria, also it is good enough. Okay, don't be very adamant that yeah, I will remember all the 10. If you remember all the 8, really good. Okay, but don't feel bad that you can't recollect all. Okay, it's humanly impossible, especially when you're under stress. If you can recall at least 6 or 7 things, it's very good. Okay, so make mnemonics of your own, whatever you want, and remember it. Okay, so there are a lot of scoring systems most of you have kept asking. So make mnemonics or look for mnemonics which are already available as and when possible when you're studying. Okay, management, you have to remember, it goes up in a systematic way. Write what you do regularly at bedside. Okay, you know that it is a particular score, it is only for 5 marks, right? So that is the reason it has gone in 3 pages. Okay, you first write about the diagnostic approach, criteria, then management, so you can finish it roughly in 2 pages. Okay, so firstly you'll do the labs because you need to use the scoring system. So what are the labs you ask for, the routine labs, the additional labs. Okay, especially if additional labs, what you focus is on viral etiology, etc. Okay, so mention about that. Okay, then you do additional testing like bone marrow aspiration, etc., to for looking for hemophagocytes. So this is something that you need to remember. Then you can write about your radiological investigation. So any question if they ask about management, so write about what you do. Okay, your investigations, then go to treatment. So if they're writing management, don't directly jump to writing your treatment per se. Write about how you work up and then you go for treatment. Okay, in treatment, as and when possible, if you know what is the goal, please mention the goals. Okay, in this particular HLH, whenever it is there, the only thing is know why it is happening, what is the inciting factor or the trigger. So you have to diagnose it early, start the supportive care, look for the etiology. Okay, start and manage accordingly after that. Okay, usually it's a multidisciplinary approach. Usually you have the hematologist and the oncologist also with you. Okay, and by and large it's a MDT management towards the management of HLH. Two protocols were famous. One is the 94 HLH protocol, the other one is the recent one, that is the 2004 HLH protocol. Only thing which was stark difference between the two is the inclusivity of the stem cell transplant. Earlier in 94 they were not including that. Right now, to based on histology of first, you can divide things, that is your first line therapy and salvage therapy. Line usually consists of your drugs like anakinra, your interleukin, pred, dexamethasone, hydrocortisone. Dexamethasone for protocol is the 90 protocol. Here, that they have to give. It is a tape, then taper it over a period of 8 weeks. Roughly 20 milligrams is what they start with. The dose 20 milligrams per meter square, okay, of dexamethasone, which roughly milligrams per day. Dexamethasone 20 per day, then slowly over the day downwards. Also consider the use of one of the first line therapies. The second line therapy, drugs like your JAK inhibitors, okay, your Janus kinase inhibitors like ruxolitinib and baricitinib. Okay, these are the drugs that you can remember. Your JAK inhibitors, if you remember, more than enough. Drugs like etoposide is also something they consider. Okay, other things like monoclonal antibodies have also been included in second line therapies. If both of them are not work, salvage therapy. The question comes here. One thing which I've also forgotten to mention here, but that usually happens. See, this is what I forgot to write when I was writing. So how will you choose? What is the cutoff factor? When will I skip from first line to second line? So you look into your H score. Okay. So if you feel that one of your parameters, like your fever is not settling, bicytopenia is still worsening after 48 hours, probably if you see your inflammatory markers are still on the higher side, also include the second line therapy. That is, your patient is rapidly deteriorating. Remember, whenever you have a case of HLH, you are desperate. Okay, despite you doing everything, every possible thing, the patient might not survive. But yeah, this is how you can systematically treat your patient. Okay, salvage therapy include plasma exchange therapy, use of monoclonal antibodies, anti-interferon C monoclonal antibodies, and sometimes induction of chemotherapy. If all of this is done and you have this patient under some control, you can post this patient. If at all he's actually fit for a transplant, you can think about doing a allogenic hematopoietic stem cell transplant. Okay, so this is in brief about the management if they ask for a management of HLH. Okay, remember this is the 2016 WHO classification, primary and secondary. There are different ways. Okay, depends on the type of cells that you talk about, and that is how they're classified HLH as. Remember the 2004 criteria. Remember your H score. Okay, H score is really difficult to remember. Just remember score more than 169 is confirmatory for HLH. Okay, so this is by and large general considerations. Optimize supportive care, check for secondary infections. Okay, rule out all of this. If possible, then you start your management per se for that thing, that is your immune suppression therapy, increasing the immunosuppression. If everything is okay, once the patient is a bit stabilized, think about allogenic stem cell transplant. Coming to the last question, it's a part B of question number 10, withdrawal syndromes in the ICU, recognition and management. So this can be one of those questions wherein you know something and you have to write an answer, and this will fetch you some good marks. Okay, so sometimes you would have got googly questions. This might look like a googly question for some people. Okay, they're like, withdrawal, what do I write? So if you think, write your answers, after thinking probably for 1 or 2 minutes, you can formalize your answer and present it in a way that you can score marks in this as well. So always remember, whenever you get a bouncer, sit back for some time, use 1 or 2 minutes of that time, think what you know about it. It might be zero, but you can link that particular topic to something and then do. This is in that way a slightly easier thing because you see this quite often, and most of you have written a good answer. Whomever I saw, you started with writing alcohol withdrawal as main thing. Yes, good enough, but mention other things as well. By this, you need to understand that withdrawal syndrome, what it is. Correct, the question is very simple. It's a 5 marker. Only they want to know, how do you recognize it, how do you manage it. Okay, nothing more than this. Okay, so how do you recognize? Usually what happens is, a withdrawal syndrome refers to constellation of symptoms that follow cessation of a drug or a substance. So if you write this, they understand that you know what is withdrawal syndrome. Then if you write what are the etiology, it can be alcohol, drugs like opioids, benzodiazepines, any antipsychotics that the patient has been taking. So then coming to recognition. So what is recognition? That is nothing but your diagnosis. How do you go to the diagnosis? It can be the clinical features, right? You categorize them as signs and symptoms. Initially, when I started writing the answer, I just wrote down the things like agitation, restlessness, fever, etc. But the other way you can present it is like signs and symptoms, right? So you organize your thought, you can write it better. So in that, you can make your signs and symptoms and present it. Okay, so most of the signs and symptoms for most of the withdrawal symptoms, withdrawal syndromes are same. Okay, it's always associated with anxiety, it is always associated with restlessness, it can be associated with movement disorders like tremors, worst case scenario seizures. Okay, so you can classify these things. Sometimes what you see is autonomic dysfunction. Okay, which it might be accelerated hypertension, tachycardia, sweating, okay, or raise in temperature. Then mention about types individually. You can mention. Okay, you can go by talking about alcohol withdrawal. What do you use? There are tools which are present like your SIVA score or your short score, etc. Okay, SIVA stands for Clinical Institute Withdrawal Assessment of Alcohol. It actually has a very good sensitivity and specificity. Trust me, when I prepared also, I didn't know this unless I read specifically and then got to know. I just thought it is by and large, recognize this and give the answer as drugs, right? Give them, your benzodiazepines. Usually what we do is chlorodiazepoxide, right? You start this, and if it's an acute emergency, give haloperidol. So we thought that was just that, but there have been very systematic tools which are present from a long time. SIVA score is one such score, SIVA AR. Okay, it stands for Clinical Institute Withdrawal Assessment for Alcohol Revised. Okay, it gives us the assessment for severity as well. Okay, if there is presence of delirium tremens, agitation, it starts with this. Worst thing what happen is it can be seizures. A SIVA score of less than 10, what you need to do is just observe this patient, probably might not worsen. Okay, uh, between 10 and 18, probably you might have to give a PRN type of a drug like benzodiazepines. If at all required, gabapentin. If the patient is extremely agitated, probably haloperidol. If the score is really more than 19, then it's a very high possibility that this fellow will develop, uh, uh, you know, um, withdrawal, probably it's better to initiate these patients preemptively. Okay, so preemptively you can start these patients on benzodiazepines and go up on the dose and the type of drugs depending on the outcome. The other type of withdrawal which are seen in the ICU are opioid withdrawal. Patients might be on opioids for chronic pain. Okay, signs and symptoms can start with pain itself. Okay, because they have had sudden discontinuation in the ICU, probably for some other reason. Okay, they can present with piloerection, excessive lacrimation, mydriasis, which is being present, sleep deprivation, etc. So these are the things which you see in opioid withdrawal. Similarly, you see benzodiazepine withdrawal and sedative hypnotics, which are more or less similar. So this is by and large recognition of withdrawal syndrome. Coming to the management, you have initial workup. I told you routine labs and specific tests. Okay, you divide it like that, and then you can give it. Okay, routines you all know: complete hemogram, liver function test. Okay, to rule out any metabolic etiology for altered sensorium. Withdrawal syndrome is the differential diagnosis is something that you need to worry about. Okay, the best thing would be you have to mention about. Differentials also. If you write that, then you'll definitely get full 5 on 5. Okay, so radiology, CT, MRI to rule out any organic causes. Start with step 1, that is your supportive care, recognition of the cause. Okay, correcting your confounders like electrolyte imbalance, hypoglycemia, pain management, early mobilization, and probably sometimes even family involvement. Step 2, to think about the cause oriented the issues, whether it is alcohol, opioids, okay, or any other sedative hypnotics. Try and bridge them. Whenever it is opioids, what they tell us, use drugs like uh, clonidine or buprenorphine. Okay, methadone also is something that you can think about. Okay, so step 3 is basically to think about prevention. So whenever you have patients on a long term drug, like be it opioids, benzodiazepines, look at the propensity for such patients to develop withdrawal. Okay, at that particular time, think about tapering or bridging these patients with some other less potent medications so that they do not develop withdrawal. So this is by and large what you need to write an answer if they're asking about withdrawal syndromes recognition and management. Okay, so one thing which I saw this, I hope this helps. Okay, this is actually there in 2023 update which they provide to us in the annual conference. Okay, you can go and read this chapter there. Okay, so this is where I saw one thing which was good. Okay, so by and large, you have to mention about each test which are doing when you're talking about workup. Okay, CIVA score, it's quite difficult to remember. Okay, it's also a very subjective tool. Just remember less than 10, 10 to 20, more than 20. That's a vague way to remember it. Okay, more than 20, definitely start. Okay, these patients are at a higher risk for developing withdrawal. Other type of scorings which they have seen are short score, like it is actually standing for sweating, hallucination, orientation, and tremor. Okay, so based on this they can do a scoring assessment and think that whether the patient is in whether a mild type of withdrawal, moderate type of withdrawal, severe withdrawal, and based on that you can choose your drugs. So this is something that I found on up to date. Okay, this is after I wrote the answer. I just looked into few sources which might help you guys. What they say is roughly minor withdrawal happens between 6 to 36 hours. Okay, so it can be a very small thing like a headache or diaphoresis or palpitations. Sometimes the patient can have diarrhea or vomiting. Okay, but usually the mentation is normal. Seizures usually occur between a period of 6 to 48 hours. Okay, it can be a brief GTCS, sometimes can be a worst case of status epilepticus. Hallucinations are usually seen in the first 2 days. Even delirium can happen within a span of 2 to 4 days. Okay, usually delirium tremens doesn't start on the first 48 hours. It usually occurs after 48 hours. So that is something that you should understand. If someone comes to you with alcohol history and you see that they were fine for the first 2 days, but after day 3 and day 4 you notice some tremors in them, probably it might be because of delirium, and such patients usually benefit with the initiation of benzodiazepines. Okay, thank you. So this actually concludes most of the things. So all the best, guys. So whatever answers you have written till now, if you have written 60%, be proud of yourself. Okay, you still have a lot of time. The whole idea was to boost your morale. Don't be saddened if you have not written, or you're like, oh, I forgot this, I forgot that. It is possible. All of us cannot remember 100%. We know that. And even if we write 50% right now, you look at it in a positive way, that you have for the 20, 30 days or 20 days more, that you can sit and build on. The goal is revision. Please revise. Okay, don't attempt reading newer topics towards the end of your preparation period. Just 1 week before, try and revise as much as possible. Okay, out of 10 questions, roughly 5 to 6 questions you will know the answer. Okay, just formulate it in your head. So prepare your answer in the head, telling that if this question is asked, I will answer it under these headings and be done with it. Okay, don't explain beyond what is necessary. If you see, most of our answers are beyond what is necessary. Okay, try and complete it to the point which they've asked. Avoid answering unnecessarily. Okay, don't prolong your answers. If they have asked recognition and management, write recognition and management. If they've asked management with evidence, just write management evidence. Write it only to the point. Don't write etiology when it is not last, like we have written, right, in a few things. This is what I wanted to point out. This is where we go wrong, wasting our time and space. Okay, remember, both are constrained in your exam. Usually your exam will not be so lengthy, it will be shorter. Okay, so they will not give you such a bad lengthy paper. Okay, they will try and balance it out. So don't get scared if you are unable to complete the thing. Don't worry. Okay, so if anything is there, please feel free to join with us. Okay, after the theory exams, definitely we will be regrouping for practicals as well. Okay, so feel free to ask your doubts about anything during that time as well. So we are trying to help you as much as possible. Okay, we will be shortly sharing the details of the practical course as well. Okay, so once you finish this, by and large, this theory will be the foundation for your practical, so prepare well. Okay, so all the best. Definitely you guys will do well. Okay, hope to see you guys soon on the other